the other exams. Same amount of time, same rules apply. Make sure you don't bring extra stuff into the classroom if you don't need to, bags to the side, all of that good stuff. We'll be given one piece of scratch paper, and I think that's pretty much it. Are there any questions about the test this week? You should be getting the hang of this with, we're over halfway through, right? So, again, I hope everyone had a safe fall break. If you have questions about the exam that you think of after this class session, feel free to email me sometime between now and Friday. I'll be happy to do my best to answer them, okay? I'm going to turn it over to Dr. Hopkins.
Monday, go Dogs. For all of you not Dogs fans, I hope you guys have a great week, and I'll see y'all next time. You guys have some pre-class material. Dr. Brandon uploaded the cases today. So I'll just let you guys sit and spend some time in your groups for the first 7 to 10 minutes. I'll touch base with you guys, see what you guys think in terms of DVT prophylaxis. Actually, the first case probably should take about 5 minutes, and then we'll come back and have some follow-up questions.
I mean, basically, he thinks everyone should have easy. Unless they're on full dose of anticoagulants. How did you do the thing where it shows you the notes? Go to print and go to print notes. That's what I thought. But you have to print. You have to put it in notes before you do that. So go to PowerPoint and then do notes right there. No, right there.
Thank you. There we go. Beautiful.
And then all the notes. Yeah.
Oh. Thank you.
You put these in a PowerPoint? Yeah. Do what? You put them in a PowerPoint?
Hold on. The cases, yeah.
Darn it. You should give him heparin. Yeah. Sorry, I haven't even opened it.
What's the high dose of heparin?
Friday, Saturday, Sunday. It's more than 3 days.
That is, no, but if you go back to heparin.
You need to be. Well, that's just for that mechanical. Oh, wait.
I think you think about stressful.
No, the,
Oh, I thought he said
these things, you just can't use them if they've been in the hospital for 3 days. It's an absolute
16-thing PowerPoint, like, oh good, and you just put
But I think he's
screenshots of the guidelines.
I think the only like contraindication is for medication, like the
I thought it was going to be brain.
yeah. Yeah, I was reading over it this morning, and I thought on one of them it said
literally on one of like this slide, it's like, I don't know.
yeah,
Okay, move it on.
on one of them I thought he said like it would be reasonable for me to test this. Dang it, let me just memorize it up, write it again. He said it would be unreasonable for me to test you on this.
Oh, the thing where they were like, we would ask them to calculate
Yeah, the scores.
Why aren't all of our tests
Chastain just is a little crazy person. Chastain's good at what he does. I just think like he tries to throw away too much on us. Yeah, exactly.
What's his range?
I mean, like, Holton's really smart too, but
will be used unfractionated? Is this like stuff bad just gets?
It's 54.
But you don't
Okay.
have to dose reduce with heparin.
Yeah, so like we don't want to use enoxaparin.
You can just dose reduce this enough.
Yeah, those are just if it's under 30, right?
Yeah.
You just put it to QD.
Actually,
Oh, well, we could do
you reduce
Levinox
the
then.
dose if it's under 30, so this would be fine. I think it's
Does it have his weight?
It's 122 kilograms. Don't you change it if they're fat?
Yeah.
So like over 35 BMI or
So for
something.
heparin, it's over 45, and for the unfractionated or for the low molecular weight ones, it's 35.
So how do you calculate the platelet count?
I don't remember.
I think
the
on the
actual
test
one.
they would give it to
Yeah, I feel like they always do.
How tall is he?
75 inches.
How many feet is that? 6 foot 3.
3?
Big guy. He's 15 point. He's underweight. No, wait, that's pounds.
Yeah, if it was 122 pounds.
he would weigh less than that too.
Oh. Not all of us.
He's 33.5, so we don't have to do it.
Someone else is talking about testing.
All right, so got a 58-year-old male who's been in the ICU for 3 days now. And for whatever reasons, past medical history, you see pertinent labs listed. So group 22, does he need prophylaxis?
Yes.
Okay. Group 18, what would you give him? Mechanical, drugs, or both?
We chose enoxaparin 40 milligrams sub-Q once a day.
Okay, so drugs only?
We could.
Sorry, that was not meant to lead you, that was just a question to clarify.
You'd have to check to see if he already has a DVT. You can't give it, if he has an active DVT, you can't give it to him. We can't give it to him right now. He's been in the hospital for a couple of days without prophylaxis, so we have to rule out if he has an active DVT already.
Okay, so you want to do drugs only, and you said no mechanical because he's been there too long, so you want to rule him out, right?
Yes, sir.
Okay. So in practice, this is something that is not necessarily drug related, but it is a contraindication to some type of prophylaxis in terms of mechanical prophylaxis. So I wanted to show you guys what that looks like in practice. Right, so when I go to order ultrasounds, so that's something that I recommend, I don't want to say daily, but probably twice a week, because people want to start them on SCDs or sequential compression devices. When I type in venous ultrasound or duplex or Dopplers, you see I have to choose lower extremity bilateral and upper extremity bilateral. Usually you can just get away with lower extremity if they've had a central line in their upper extremity for those 72 hours, and the upper extremity could also potentially have a DVT. But if that patient does not have any type of central line or any venous catheter in their upper extremity, then you should be okay just to get away with lower extremities. But yeah, so you got to order these, and then they'll just ultrasound their arms or legs or both to rule out a clot prior to. So once this patient so I think group 18 already answered that what they would do. So group 7, what drug and dose would you give?
Enoxaparin 40 milligram.
Okay, 4 times a day?
Once a day.
40 milligrams once a day, okay? Group 25, you guys do anything different? Agree, disagree?
Yeah, we agree with enoxaparin, but we also said heparin 5,000 units every 8 hours. But he's obese, so we would increase the dose.
Okay, so what would you, if you chose heparin, what would you specifically do?
It's 5,000 minutes, right?
Yeah, 5,000.
Oh wait, he's over 100 kilograms.
Yeah, we would increase the dose. We don't know how though. We don't know what.
Okay. And you want to do Q8 or Q12? Or you want to increase it from Q12 to Q8?
Q8.
Okay. So we want to do a Q8. So you have a few different options. So remember, this guy is large. So in the pre-reported or in the pre-class material, I said with a BMI over 45 or if you're over 100 kilos for heparin. I'm more aggressive with that personally, but based on the literature, you're probably at least safe enough to say a BMI over 45. But this guy's over 100 kilos, so that's another cutoff. So I go up to 7,500. Some places you may even read to do 5,000 Q6. There's a lot of gray area with regard to heparin dosing. As long as you guys know that 5,000 Q8 is your benchmark, and then you would either go down in small patients or old patients, or you would go up to something in larger patients based on the BMI or total body weight.
Thanks.
So because it is a much grayer area, I wouldn't ask you guys on an exam, like for a free text, what it would be. But I would hope you guys would identify what a higher dose would be. Okay. Very similarly with enoxaparin, so they have a BMI over 35. Also, if they're over 100 kilos, try to be more aggressive. So 40 milligrams again is your standard dose once a day. But because this guy's larger, I would go up to Q12. Some evidence even suggests, again, like in the pre-class material, to do 0.5 milligrams per kilogram Q12, which in it would be 60 Q12. So again, as long as you guys know that in bigger patients, you should be more aggressive with dosing, then that is the take-home message.
Would you consider not being as aggressive with the enoxaparin because his low creatinine clearance?
So if you look at his, I mean, in general, absolutely. Personally, in the ICU, I don't trust anybody's renal function, and so I have a preference to never use enoxaparin in the ICU until they are ready to transfer, or until they have already transferred. However, that's not to say that that is guideline, that's not evidence-based, that's just my personal preference, and we'll talk about that a little bit later as well. He's got a creatinine of 2.1. If you go back and calculate his creatinine clearance based on his adjusted body weight, etc., I think his creatinine clearance is right at 60. So based on his creatinine clearance, you do not have to renally dose adjust your enoxaparin yet. That's not to say I didn't give you any information about the urine output or anything like that. So based on just what I gave you, I would not dose adjust yet. Does that answer your question adequately?
Yes, thank you.
Okay, good. So same patient. So what would you do differently if he was admitted yesterday? So he's been here for 3 days. And we said we would do drugs only. So if he was admitted yesterday, group 2, what would you guys do differently if he was admitted yesterday as opposed to Friday?
I thought you said something sassy about boxing too.
We would just do mechanical prophylaxis.
You would do mechanical prophylaxis and no drugs?
Right.
Okay. Group 4, you guys agree or disagree?
We would do both mechanical and drug prophylaxis.
Okay. So why would you choose to do drugs, add pharmacological
Honestly, I have no idea.
Okay, good. I'll flip it back to group 2. Why do you guys not want to give drug therapy if this patient was admitted yesterday?
You can just like chug it.
Oh, there's probably cubes in my coffee to make it lukewarm.
So I got one group saying mechanical only. I got one group saying both. Group 10, do you want to vote and split the tie?
Was that drug and mechanical?
Okay, so why would you add drugs to the patient even though he was admitted yesterday? So if group two was serving as the physician on rounds and said, I only want to do mechanical prophylaxis, I did not want to start pharmacologic prophylaxis on this patient, but group 10 you want to, so what would you say to the physician to counteract what they said in terms of starting drug therapy?
No, I think I can do mechanical.
We would just say that since he's not at a high bleeding risk, it's more important that we prevent the possibility of a thrombus forming than worrying about any excess bleeds or anything.
Okay, he's at low risk for bleeding, but because he's immobile inpatient, he is at high risk for clotting. So just the risk-benefit ratio. Okay, that was group 10?
Yes.
Okay, good. Yep. So I would add mechanical prophylaxis in addition to drugs. Right? He is immobile immediately. As soon as he's admitted to the hospital and thrown in an ICU bed. Certainly, we try to do early mobility and get these patients up and moving. But until they can prove to me that that's happening on a regular basis, then they're getting full gamut. So what if his platelet count was 27,000 through 12? What would you do differently for this patient if his platelet count was 27,000?
We just do mechanical prophylaxis? No drugs.
Okay. What is your platelet count threshold to turn them off? To not do drug therapy?
100,000? Question mark?
Okay. Heard some Will Ferrell there. Yes, so there's some evidence to say 100,000. Some of the physicians I work with say 100,000, some say 75,000. There was a picture that I put from the guidelines in your pre-class slides that helps. It's like a risk scoring tool. I don't ever use any of those risk assessment tools in practice. Just personally, some people probably do. But I personally practice platelet count less than 50,000 or less than 30,000. So less than 50,000 I think is a good number for you guys to know, especially for an exam. If somebody says I hold it for less than 100,000, I'll probably raise my eyebrows and look disgruntled just to challenge them enough. But less than 50,000 should be a good answer for you guys to know. Okay, good.
Dr. Hawkins?
Yes, ma'am.
Oh, I just saw the new question pop up on the screen, but I was going to ask about fondaparinib when the platelet count was 27,000. Like, would we initiate him on that, or would we just do no drug therapy if his platelet count was 27,000?
The answer would be, just based on the information that you and I have looked at on the slide, the answer is no drugs at all. Fondaparinib is still an anticoagulant. So it would still put him at risk for bleeding. So for that reason, you would say mechanical only. Now, if his platelet count dropped have a different conversation, which is what we'll go to now. So if he was diagnosed with HIT 4 days ago and is now on an argatroban infusion, so argatroban treats HIT, what would you do differently? So how about group 14?
Do we have enough info? Is it working?
Okay, so we're talking about prophylaxis. So what type of drug is argatroban? And I'll open this up to anyone in the class on all campuses.
Yeah, it's a 10A inhibitor, right?
Yep, so he is on, or he's just a, direct thrombin inhibitor. And it's a continuous infusion anticoagulant. Right, so this is actually pharmacologically, and this is systemically anticoagulating him. So this is very similar, relatively speaking, to putting someone on a heparin infusion. Right, so he is on high dose anticoagulation to actually treat his HIT. So he does not need any prophylaxis because he's already fully anticoagulated. Or no drug prophylaxis, I'm sorry, he would still need mechanical prophylaxis.
Anticoagulant.
What if his serum creatinine yesterday was 0.8? You see on the first slide that I gave you, his creatinine today is 2.1. He's had no urine output since midnight. How about group 16?
Okay, but that's okay, just put it up in there.
I didn't realize we were adding these cues.
The conference call day today.
Just make sure whatever you have.
We have to do it right. Because it's tomorrow. Which one's it start?
I think we'd still get heparin as long as his result, this person is also
Okay, yeah, so good point. So sorry, I'm ignoring the other stuff. Just if this original patient, and then we're just going through different what if criteria. So if the original patient had a creatinine of 0.8 jump to 2.1 and no urine output, so you would continue mechanical and then you would specifically choose heparin and you would say absolutely no enoxaparin, or you would just choose a different dose of enoxaparin.
We would potentially give enoxaparin, but is it bad to give heparin?
I think that was a question.
Yes.
Okay, so actually I would only give heparin. So this patient effectively has a creatinine clearance of 0, right? He has no urine output, and we know that enoxaparin is renally cleared. So for that reason, I would say no enoxaparin for this guy, because he is definitely going to accumulate, not excrete. Heparin, you do not have to worry about renal excretion. So heparin would be the only, in addition to mechanical prophylaxis, heparin would be the only drug therapy that would be appropriate for this guy. There's also remembering that fonterafenux is contraindicated with a creatinine clearance of less than 30. So any questions about any of these discussions that we've had before we move into case 2?
Do we need to know how to choose between the two different kinds of mechanical prophylaxis, or should we just know that he needs mechanical prophylaxis?
Yeah, just no mechanical prophylaxis. It determines a little bit more if you're inpatient versus outpatient, and then what your hospital carries. But in general, you're probably going to hear me not even say mechanical. I'll probably accidentally say SCDs, because that's what probably most people are familiar with. is the more generic term that are written in the guidelines. You don't ever see SCDs anywhere, but the two institutions I worked at, that's what we've always called them. Any other questions about any of these discussion points before we go to the next case?
Do we generally give patients mechanical unless they have a contraindication to it, just sort of everybody get it?
Yep, so that's a good question. So I would take your statement and I would double it to say that every patient should get mechanical and drug prophylaxis unless they are contraindicated. Maybe on the floor, again, if you're, because mobility is a risk factor. So some physicians will argue, well, if they're on the floor or some even in the ICU, oh, well, they're able to ambulate. Well, being able to ambulate and actually ambulating are two very different things. So if you are up and walking around very consistently throughout the day while you're inpatient, then sure, you can get away with maybe drugs only, or one or the other. But in general, even though patients are able to mobilize, they are not actually up walking the floor 4, 5, 6 times a day. Good question. Any other questions before we go to case 2? Okay, I'll give you guys a few minutes to look over this and we'll come back.
Okay, our person is underweight. 122. No, she's 46.
I'm so sorry. I'm just all up in you.
It's a related case. Let's see here. I never remember our stupid fishbone.
All I know is that this is glucose and that's sodium and that's sodium.
What are you looking for?
Which one's the?
What numbers
It's
are
this.
what in the
It's
stupid
154.
In the X.
It's the right one.
Yep.
What's white blood cells?
What's raised?
Ray's Coastal Cafe.
Who's that?
Walton Lane.
All this food you're looking at is making me hungry. I literally just ate breakfast.
They're sitting there asking me to pick a restaurant for lunch.
Oh, this makes it bigger.
That Hildebrandt seems like Caleb written all over.
It is really good. That's the one. Where is it?
6th Street.
There's one restaurant in the middle.
Batman?
Batman's good.
Batman was
You wanna
good.
go
I was
there?
thinking Batman.
Let's go there.
Okay.
Batman.
That's funny. I was definitely some Batman.
It used to be on like Washington Road.
Oh,
And
really?
then moved to that.
like megacolon. It just sounds so badass.
Yeah.
All right, on behalf of Group 21, Marcus, do you think this lady needs VTE prophylaxis?
Yes, she does.
Yes, she does. How about Group 5? Do you think she needs mechanical prophylaxis or drugs or both?
Both.
Both. Okay. Group 26, do you agree or disagree?
Agree.
Good. How about Group 17? Which drug at what dose?
What's her serum creatinine? Do you think we should do heparin at a reduced dose? I don't know. I don't know what her serum creatinine
Creatinine
is.
clearance is.
Oh, we do a reduced dose.
Because she's less than 46 or 50 kgs.
Yeah, just heparin.
We would do unfractionated heparin at a reduced dose since she's under 50 kilograms.
Okay. So give me some.
We don't know.
Is there a make?
So 5,000 Q8 is your standard. So how would you?
5,000 Q12.
I mean, we could do every 12 hours.
Okay. So you would do heparin 5,000 Q12. Group 11, you guys agree or disagree, or is there anything else you can do?
Dr. Hawkins,
Yep.
so when trying to figure out if she was a candidate for mechanical prophylaxis, I know it says that she's post-op day 1, but we couldn't figure out if she was in the hospital prior to the surgery, and we also didn't know what the 2/2 meant.
Oh, okay. Sorry. So this is for septic shock secondary to C. diff and toxic colon. That is a great question / point that would need clarification. But I guess when I was writing the case, she got here and then immediately had surgery based on her current condition. So she is post-op day 1, maybe hospital also day 1. So that is a great question that I should further clarify.
Thank you.
Okay, group 17, I think, told me heparin 5,000 Q12, and group 11. Anything you guys wanted to do differently, or do you agree or disagree?
We agree. We could also do enoxaparin 40 milligrams q.d.
Okay, enoxaparin 40 milligrams once a day. Group 19, you okay if you were the pharmacist and the physician ordered in this patient enoxaparin 40 milligrams once a day, would you verify it or would you reject it and call them? And if the latter, what
I
would
would
you say?
call them and try to switch it to 30.
Switch it to 30, or you mean change the dose from 40 to 30?
Change the dose from 40 to 30 because of her
Okay.
low weight.
Okay, so you would change it based on how much she weighs. Okay. So 2 things I want to bring up here. 1, definitely agree that heparin 5,000 Q12, if you're going to choose heparin, Q12 is definitely the right way to go, being that she's, 46 kilos, I believe. I have question marks here because, so first, if you're going to use enoxaparin, I would definitely dose reduce, again, because of her weight, to 30 milligrams Q24. The big question I would have, even though I told you, and this is just for more practical considerations, she is deemed low bleeding risk, which is how I would write it in an exam question. Clinically speaking, she just had a surgery. So even though she's low risk, there is still a chance of bleeding, right? And if you think if heparin can be given every 8 or 12 hours, it has a much shorter half-life than enoxaparin that's given once a day, right? So if this patient either A, started bleeding, or B, had to go back for a follow-up surgery, they had to reopen her or start cutting on her again for whatever reason, you would have a longer-acting anticoagulant sticking around. So, my personal opinion, I'll ask Dr. Brandon what her practice is. Again, my preference, generally speaking, in the ICU because of easy turn-on, turn-off, as well as bleeding risk or the need for an emergent surgery type situation. I like heparin specifically for the turn-on, turn-off. Dr. Brandon, do you have any comments about that?
I agree with what you're saying. Like, my personal preference is always do infractionated heparin. I think we kind of both have a similar practice style until we kind of avoid long-acting things. I will tell you that I work with a lot of physicians who prefer to use enoxaparin. There's some data that suggests that enoxaparin may be potentially superior to infractionated heparin. So again, it's a situation where I'm not going to argue with someone because I have a personal practice style. They ask me for my recommendation and I have a preference, but if they wanted to use enoxaparin, I would definitely use a smaller dose in this patient, just similar to what your discussion is because of the low body weight. But also recognize that when you're looking at syringe sizes of enoxaparin, the small syringe size that comes in is a 30 milligram syringe. So if you are going to potentially check a 10A, I mean, I know you're going to talk about this later on in the cases, but if you're going to check a 10A level on this patient later and they're still receiving too much anticoagulation, then there's really not a lot you can do at that point trying to give a smaller dose of enoxaparin unless you also, I'm not going to get into that actually, just know that that's the smallest syringe size that it comes into. So sometimes I will have that discussion with the physicians too, like if this is too much, then we're going to have to potentially go to infractionated heparin, doing it Q12, and then if that also is too much, then we may have to back down the dose of infractionated heparin too, which is much easier to do than with enoxaparin.
Yeah. All right, good. Thank you for that, Dr. Brandon. So, generally speaking, especially for an exam, either of these answers would be correct, right? She has good renal function. She is, in general, at low bleeding risk. So as long as you know that both drugs would be appropriate based on their renal function, their bleed risk, and that because of her body weight, that you would dose reduce, okay? But good to also see how some of that translates over to practice. Okay, we'll come back and I'll ask general questions before we move to case 3. So, what would have to be different in the patient for you to say mechanical prophylaxis only? Right, so how would I ask the question? How would I change this patient case so that mechanical prophylaxis only would be the correct answer? So I'll give you guys a second to think about this because it's a backwards type question. So group 20, how might I change this question so that mechanical prophylaxis would be the only appropriate thing to do?
If the patient is already on treatment anticoagulation.
Okay, that's a good thought that I didn't actually have. So if they were on treatment anticoagulation for some reason, or just in general, which kind of falls over into that, if they had a high bleed risk. Right, if I would have specifically said they had a high bleed risk. What if heparin 5000 Q8 was the only right answer? Instead of, well, I don't want to say the only right answer, but if we originally said that heparin 5000 Q12 was the right answer, so what if the right answer would have been 5000 Q8?
if the patient wasn't obese or small, they're just like regular size.
Okay, so I would give you more specific or better information regarding their total body weight being between 50 and 100 kilos, or I would tell you that their BMI was a normal range, less than 45 or above 22.5, whatever normal is. Okay, good. What if against enoxaparin? So what would make you say that enoxaparin was not a valid option? So we said heparin or enoxaparin. So group A, what would make you say that enoxaparin was contraindicated and heparin was the only answer?
If she had poor renal function?
Yep, good. How about what if fondaparinone was the right answer? How about group 13?
If the patient had a history or concern for HIT?
Yep, good. And then lastly, what if apixaban was the right answer? How about group 24?
Where did you come up?
They're already taking it, right?
Yeah, that seems like
The piece was already on.
Maybe if they were already on it, apixaban for something like AFib, and so they don't need to be anticoagulated with anything else.
Okay, so that is another good point. So maybe they were on apixaban at home for AFib or some other recent history of a thrombus where they required systemic anticoagulation. So I didn't think about that. Also, if I changed them their type of surgery, and I said that they had a recent, if their surgery was not intra-abdominal for infection, but it was orthopedic. So in orthopedic surgery, you got a lot more options in terms of DVT prophylaxis. Most of that is going to be very specific. Again, the guidelines are very specific in terms of what type of surgery, etc. Any other questions about case 2 before we go to case 3, just for all these different discussion points?
So if you have poor renal function, I know on our pre-lecture slide it says if the creatinine clearance is less than 30, you reduce the dose for enoxaparin, but you're saying it's contraindicated in poor renal function?
So that's a good question. If your creatinine clearance is less than 30, you can dose reduce. If there's really no good answer anywhere else, Dr. Brennan may be able to weigh in, but in general, if their creatinine clearance is less than 30, I don't use enoxaparin at all. But maybe if it's less than 20, you could say that it's contraindicated. Dr. Brennan, do you have any comment about that? What renal function would you say is no enoxaparin?
Okay, so, well, because I work with nephrologists who will use it in hemodialysis patients, but I also work at an institution where we can check 10A levels in-house and they come back in a couple hours. So my previous institution, we couldn't do that. So if their clearance was less than 30, I just avoided using it. And most of the clinicians I worked with were in agreement with that. So I would just say, I always sort of err on the side of being a little bit more conservative just for the chance of potential bleeding in the ICU. So I would say if their clearance is less than 30, I'm always going to bring up trying to change them to unfractionated heparin at that point. For sure, if they're less than 30. Honestly, if they start trending below at 50, then I'm going to start bringing that up as a conversation point anyway to start talking about that. But for sure, if it's less than 30, I like to get away from it.
And I understand that still did not clearly answer your question. So I apologize for that. But again, it's just because it's like a grayer area. So on an exam, as long as I'd say if you know that less than 30, that you should dose reduce. If it's less than 30, dose reduce. If it's less than 10, it is contraindicated. That is my own executive decision that is non-evidence based, so that you guys can carry forward on an exam in a black and white type of answer, and also in practice would really prefer you to understand that less than 30, you should not use enoxaparin, but understanding that you still potentially could.
Great, thank you.
And I'll make a note here to make sure that that is a true statement. That's a good question. So any other questions before we move to case 3?
I have a question. So for case 2, you're giving her either the unfractionated heparin or enoxaparin because of her weight, right? So if she was within a good weight, then you could give both.
I'm sorry, I don't think I understood your question.
So basically for the VTE prophylaxis, you said for case 2 that she should get unfractionated heparin, right, 5,000 Q12, or enoxaparin 30, right?
Yes.
So if she had a weight that was, within normal range, would you use both of those? Not just one of them?
Are you saying both in combination?
Yeah.
No. So you would never use both of them at the same time. It's one or the other. The reason I have both of them listed here is because both of them are potential options. And specifically, both of them are dose reduced because of her low body weight.
I was laughing at that.
Okay, thank you.
Is that unclear to anyone else? I'll ask that. Okay. Case 3. Make sure there's no abbreviations in here you guys are unaware of. ASA aspirin.
What does ASA
Alpha Place, TPA.
You're just joking.
Okay, I'll give you guys a minute to look over this patient. And we'll come back.
I don't get Kendall is like, oh my gosh. Get out of here. Okay. He's 6.
So that means he's at a stroke risk, or he's at stroke.
Is there a certain amount of time that you can't get?
I don't know, but I know stroke, there's something to do with stroke. I'm trying to find it.
Previous VTE.
Okay. It's recommended to use low molecular weight heparin over unfractionated, or the intermittent pneumatic compression. Oh, I just zoomed in.
Oh. Right.
So for the ischemic stroke, you use low molecular weight heparin over unfractionated.
It's just that it should be delayed 24 hours.
Did you see that somewhere?
It's on the PT ischemic stroke thing. At the bottom, it's underlined.
That's a week. Yes. Yes, like
Oh, it's the next one. Okay, gotcha.
But that's intracranial hemorrhage.
No, that's the ischemic stroke.
Yeah, it's,
intracranial hemorrhage is 48 hours.
It's this one.
Oh, that says 48. I literally cannot read.
Here, I'll have to zoom in on this one. So we just, yes, that we delay it 24 hours. Wait, doesn't it say you did it one day ago, or did I just make that up?
Did what?
We did yesterday, okay.
Okay, so first question you guys have is, does he need prophylaxis? So group 19, yes or no? Would you prophylax him?
That's what time it is. Doesn't it have to be like a TPA after? So he got TPA.
Well, first, I guess we would need to know if it's been at least 24 hours since he received the TPA, because I guess it's contraindicated within 24 hours.
Okay, so he was admitted at 1 p.m. yesterday afternoon. So he definitely got TPA after 1 p.m. yesterday afternoon.
So it has not been 24 hours, is that what he's saying?
Just ask the same question again.
We would hold it for right
What?
now, but we would still want to do VTE prophylaxis in the future.
Okay, so So he does need prophylaxis?
Yes, he will, because, just because he's on the dual antiplatelet therapy doesn't mean that we should hold, the VTE prophylaxis.
Okay, and remember that you're talking about drug or mechanical prophylaxis. So does he need prophylaxis right now?
We can do mechanical prophylaxis right now, just not pharmacological.
Okay, so we just actually hit on both questions at the same time. So yes, he needs prophylaxis. Group 19 says he needs mechanical only. She would not do drugs. Group 23, do you agree or disagree with this?
Agree.
Okay, you agree to do mechanical only until sometime in the future. Okay? We'll say group 6. What drugs would be appropriate to give, and when would you say to start them? So kind of to take group 19 and 23's thoughts and put them into a plan.
We would do enoxaparin 40 milligrams STQD.
Tell me that last part again.
Enoxaparin 40 milligrams subcutaneously QD.
Oh, okay. Group 8. Anything you guys want to, any different options that you guys would choose? Or do you agree?
We would do heparin 5,000 units, subcutaneously Q8.
Okay, y'all do heparin 5,000 Q8. And group 15, when would you specifically, when you order these drugs, when would you put it in to start?
Wait 24 hours after the TPA was administered.
Okay. And then just for the tiebreaker, because one group chose enoxaparin and the other group chose heparin, which one would you choose?
Heparin.
Okay. Yep, so again, both of these would be correct. Just remember that you can't start them until at least 24 hours after the TPA. So I don't know when, you could look back at the chart to see the exact time the TPA was given. What you do know is that she was admitted somewhere right at 1300, so definitely not any time before then. What would have to be different in this case to make you say I would not give any drugs, period, and mechanical prophylaxis only? How about group 15?
A high bleed risk.
Okay. Group 6, anything you want to add to that?
We also said high bleed risk.
Yep, okay, high bleed risk, and also the last case, or if they were on systemic anticoagulation for whatever reason. Group 19, when would you go against mechanical prophylaxis?
If they've been, I think it's just that.
When would you say drugs only?
For more than 3 days, and then if they haven't had it, then I don't know.
Dr.
Hawkins, I have a question going back to the
Maybe
last
TPA
slide, if that's okay.
Okay. Group 19, just be thinking.
So I'm wondering, since he's on the dual antiplatelet therapy, and because he did have the TPA yesterday, would we potentially increase the time between unfractionated heparin from 8 to 12 hours?
I would say no. I'm trying to dig into your brain why you're thinking that. You want to dose reduce because you think he is at a higher bleed risk, correct?
Yes.
Okay, so if he's at a high bleed risk, then you could argue to just not do drugs, to just give mechanical only. However, the guidelines specifically say your bleed risk has, just from the TPA standpoint, ignore the dual antiplatelets, just from TPA. TPA has a pretty short half-life, relatively speaking, so 24 hours out, you should ignore the fact that TPA is there. Because any bleeding that happened, hopefully should have already happened. So for that reason alone, you would not dose reduce. And then for the dual antiplatelets, neither of those have been shown specifically to serve the purpose of preventing DVTs. So you would still give prophylaxis, and you would only dose reduce if you think the dose that you have would contribute to further bleeding. And I don't necessarily say there's enough evidence to say that's true. Some people will still potentially argue that, but in my practice, I would still say that Q8 is appropriate. If somebody said Q12 because they're on dual antiplatelets, I probably would, again, just look disgruntled and show them that I'm not pleased, but I would not fuss about it as much. Does that closely answer your question?
Yes, thank you.
Okay. I think we were right here. Nope, I already passed it, sorry. So, what would make you choose against mechanical prophylaxis? Right, so we already talked about in the first patient, if they were in the hospital for at least 72 hours, then you have to rule out the clot with a venous duplex, or a Doppler, and ultrasound. Or if they had severe wounds or venous stasis, and definitely if they had an active VTE, which hopefully they should be on systemic anticoagulation as opposed to just prophylaxis, but definitely no mechanical prophylaxis if they have a clot in their leg. How about group 10? When would you choose enoxaparin 30 Q24? So what would make you dose reduce the enoxaparin? Let's say group 10. So group 10, when would you, if you were going to choose enoxaparin, you originally chose enoxaparin 40 Q24. So what would make you specifically on an exam choose 30 instead of 40?
We would give the 30 if their creatinine clearance was less than 30.
Okay.
Or if their total body weight was less than 50.
Yep, there you go. So definitely less than 30, and again, to reiterate what we discussed earlier, if their creatinine clearance was less than 10, enoxaparin would be contraindicated. All right, case 4. I'll give you guys a couple minutes to do this, and we'll go, and then we'll come back.
Dr. Owens, I have a question about case 3. TPA and the waiting 24 hours, I see where it says that in the stroke guidelines, but like further up, it just mentions like post-surgical patients. So I wasn't clear on if you always had to wait 24 hours after TPA for any stroke patient.
So stroke, I mean, you're only going to get TPA in an ischemic thrombotic stroke. I mean, there are also hemorrhaging strokes, hemorrhagic strokes. So for them, the guidelines just say, and I think I put that excerpt in there as well. It says wait at least 1 to 2 days. So I normally, or at least wait. It says start it between days 2 and 4. So if you have a hemorrhagic stroke, then I always wait at least 48 hours. Is that your question? What type of stroke would you do things differently in? Or are you asking specifically around TPA?
I guess even in the section on ischemic stroke, it says in stroke patients undergoing hemicraniotomy or endovascular procedures, we suggest blah, 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 and then it says, in which case prophylaxis should be delayed 24 hours if they received TPA. So there's not a guideline about TPA in ischemic stroke patients that don't have hemicraniotomy or endovascular procedures.
So that's gonna, yeah. So they make, because I would say 90%, well these days maybe like 70% of your stroke patients are not going to have an endovascular procedure. Endovascular procedures are becoming a little bit more common, but I would say 70 to 80% of your stroke patients are either going to not get any TPA or they're going to get TPA only. And then another probably like 30 to 40%, 20 to 30% may get endovascular procedure, and maybe like 2% of patients are going to get a hemicrania. So those patients are very specific, and I would say you would probably talk to the neurosurgeon that did the actual surgery to determine bleed risk based on any type of intra-op complications. But in terms of the endovascular procedure, where they like do a coil or where they go in and do the embolectomy, you would still probably you'd be fine just waiting at least 24 hours. But in none of those patients, I would never give it sooner than 24 hours. Does that answer your question?
Yes, thanks.
Okay. Sorry, you guys are seeing there's a lot of ambiguities here because in very few places do they ever say what constitutes high and low bleed risk. They just give you that generic term, and it's up to you as the clinician to decide. Okay, so we got a 84-year-old lady on the medical floor with breast cancer and mets to the lung. She's on palliative chemo, and she's got recent history of bleeding gastric ulcer. So does she need VTE prophylaxis? And if so, what? So how about group 2? What do you guys think? Does she need prophylaxis?
She would need prophylaxis.
Okay. And how about group 8? Would you do mechanical or drugs or both?
Mechanical.
Okay. Group 13, do you agree to only do mechanical?
Yes.
Okay. Yep, so how about group 16? Any other thoughts about this lady? Any other potential options you can give to help mitigate her risk for getting a clot? Sorry, maybe that was too ambiguous of a question. Right, so if you look at this lady, right, she clearly has a risk of bleeding because she recently recently had a gastric ulcer, a bleeding gastric ulcer. She also has a platelet count of 18, right? So clearly she is at a high bleeding risk. However, she is also at a very high risk for thrombosis. She has cancer, she has mets. So cancer alone by itself significantly increases your risk of clots. So this would be a great patient where you might consider putting in an IVC filter, right? So an IVC filter, put this little net in so that it, certainly lower extremity DVT sucks, right? It hurts. But what's even worse is that when that lower extremity DVT develops and breaks loose and causes a PE, right? Because that's, at the end of the day, that's what you're really scared about, because that's what's going to kill you. So when she goes home, because obviously this is going to be more permanent than just inpatient prophylaxis, this would be a good patient to probably have this discussion. And she's 84, so you definitely don't want her to go out with a clot or hemorrhaging everywhere, especially given her recent risk and her platelet counts. So this may be a discussion. The problem with IVC filters is that, especially, you only are going to use them in somebody at high risk for clotting, right? Is that once they develop a clot in their leg and it breaks loose, it goes up and it's going to get caught on this filter, and then it can end up becoming prothrombotic, right? So normally you would put it in, leave it for some extended amount of time, maybe 3 months, 6 months, for whenever their risk goes away or is lessened, and then you can go in and remove it. Other complications, obviously you see that it can perforate, it can accidentally float around, you see that it can migrate, so it can definitely cause some problems. So in general, these things should be used in a very, 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 very small, specific patient or case-by-case basis. Now this lady's 84, you could easily argue that she's old enough, she's on palliation, and so we will just not even deal with the risk of the IVC filter and just send her on her way. But this would also potentially be a good case, potential role for one.
Dr. Hawkins, I thought we only used the filter, the IVC filter, if she had an active DVT and we were just preventing a PE.
No. If there was an active DVT, then absolutely she would go home with one of these. Otherwise, she's still, just because of the risk that I mentioned, she definitely has a very high risk for VTE just based on her cancer. So yes, if she has an active VTE, we would do it, but also just generically speaking, if she's at high risk for a VTE.
I think on the slide you should have put like
You okay with that?
in between like these two things.
Yes, thank you.
Okay.
I think it's like either or.
So other comments. So I just wanted to talk, Dr. Brandon mentioned it a little bit ago, some options for monitoring, right? So you can use anti-10A levels, right, to check for appropriate prophylaxis. But you're only going to do that in patients that you are still suspicious of high bleeding risk or still high thrombotic risk. So in patients that are very underweight, where you're still at risk for overdosing them, like if you're using enoxaparin 30 milligrams once a day in the lady that was, I think, 40 kilos, that might be a patient that you would check an anti-10A level because she was, I think, recently post-op. And if their anti-10A levels were high, then you would say, or if you see that you're over anticoagulating her, then you would probably have to go to heparin, or you would have to do nothing at all because she's too small and you're overdoing it. Because as Dr. Brandon said, that the Lovenox only comes in, the lowest is 30. So you have to trust that somebody could smash or squirt out, 10 milligrams and only give her 20 or something. You can't really monitor heparin. For heparin sub-Q, for prophylaxis, there's no data in terms of monitoring the patient at all. So Lovenox is the only one you can potentially check anti-10A levels in. So you're only going to do that in patients where you're at risk for overdosing them because they're really small, or you're at high risk for underdosing them because they're really big. So some institutions will say we'll check anti-10A levels in any patient receiving Lovenox for prophylaxis if they're maybe over 150 kilos or a BMI over 35 or 40. Dr. Brandon, do you know what y'all's protocols specifically are in terms of who you monitor?
Yeah, we do. I check 10A level and anyone who's actually over 100 kilos, if their creatinine clearance is less than 50, and then if they're in the ICU, there's some clinical discretion about if we can check them or not if they're in the ICU alone with none of those other things.
Okay, good. And then the reason I put APTT on here, and it kind of goes with the next bullet here, is I have seen over and over from year to year is everyone will accidentally choose heparin prophylaxis as IV drip, right? You guys have learned about heparin continuous infusions, which is IV, and that's to treat. That is to systemically anticoagulate a patient, not for prophylaxis. So APTT can be used to monitor heparin, but only when it's given IV. And heparin IV is not given for VTE prophylaxis. Okay? So when you're talking about VTE prophylaxis, heparin IV should never be in conversation. Only heparin sub-Q. Any other questions before I turn it over to Dr. Brandon so she can go through her stress ulcer stuff? Cases.
Okay, all right, well, we're going to switch over here in just a second. So if you want to start looking at case number 1, so we're going to use a lot of the cases that you guys just did in VTE prophylaxis and look at them again from a stress ulcer standpoint. So if you want to take about maybe 5 minutes to re-look at case number 1 and then talk in your groups about stress ulcer prophylaxis for this patient, and then we'll come back. Okay. Okay, so we have the same patient that you had before. You have this 58-year-old gentleman. He was admitted to the ICU last Friday. He has an acute COPD exacerbation. He's on the vent. So group number 1, tell me, did you guys decide if he needed stress ulcer prophylaxis?
We said yes because mechanical ventilation is an indication for stress ulcer prophylaxis.
Okay, all right, and then what did you choose to give?
Famotidine, 20 milligrams every 12 hours IV.
Okay, all right. Group number 9, did you guys do the same thing or have anything different?
No, we did the same drug.
Same drug and same reasons? Okay, all right. Okay, so yes, I would agree this patient needs stress ulcer prophylaxis. I think you guys have quickly identified that he has one of the major risk factors, so he's on mechanical ventilator for at least 48 hours. And then in terms of medication, I didn't list all the specific ones, but I agree. So you actually could either do an H2RA or you could do a PPI here. So either famotidine or ranitidine or any other PPIs you could do for this patient in this case. And as we go along, you guys can ask questions just like you've been doing. Let me know. Okay? All right, so I'm going to give you guys about maybe 5 minutes to look at case number 2. Case number 2's got 2 parts to it that you can see, so look at both of those parts and then we'll come back and talk about case number 2.
Can I ask a question?
Yeah, of course.
So, since the patient is obese, you don't need to increase the dose or anything, right?
Yeah, no, so for stress ulcer prophylaxis, in terms of obesity, we have no data to suggest that our obese patients need higher doses of any of the medications when it comes to either H2 receptor antagonists or PPIs. So different from VTE prophylaxis, more looking at some of them have to be renally adjusted, but mainly your H2RAs have to be renally adjusted if their clearance is less than 50. So, but good question.
Glasgow coma score.
Where do you see GCS?
Slide at 9 for the major indications.
Oh. They need it because they have respiratory failure, right? I guess.
Why do you say they have respiratory failure?
Because it says she returns to the OR on the ventilator with post-operative respiratory failure.
What?
We're on case 2, right?
Yeah.
Yeah.
What do you think that?
It's like,
She said there's a different second part to it. I was looking on the PowerPoint.
oh, wait, did we already do the first part? Oh, okay.
Take me away.
Yes.
We did.
Me and Caleb were discussing yesterday if we were going to alcohol.
Is she really super duper Christian?
No, she is.
A lot.
Thank you.
Is it like a problem?
Yeah, no. She drinks wine and things like that. Super totally good.
It's your wedding.
Like they have to hide the alcohol in their house if like her parents
All of it. They'll probably die before your wedding anyway. It's just a problem. Just hope for the best.
hope for the best.
Hope for the best. Hope they'll die before your wedding.
Hope they'll die before your wedding. I have to quote that one. Yeah.
I have to wait a little bit since it's your birthday. But it's just insane.
Okay, so we'll start looking at case number 2. We've got a 49-year-old female, 10 cases before, who's admitted today for septic shock secondary to C. diff and toxic megacolon. She's had a partial colectomy. Now she's coming back from the OR. She's on the ventilator with post-op respiratory failure. So, group number 20. Tell me, did your group decide this patient needs stress ulcer prophylaxis, and why or why not?
You said yes because she has a septic shock and she's on ventilation.
Okay, and then what did you choose to give her? Medication. Okay, all right. Group number 25 in Savannah. What did you guys talk about in your group?
Yes for the septic shock, but we don't know how long. For the ventilator.
Okay, I think you're cutting in and out. So, yes, you guys decided she needed stress ulcer prophylaxis.
But we don't know how long she's been on the vent.
Okay, all right. So you did or did not choose to give her stress ulcer prophylaxis?
We did.
Okay, and what drug did you choose?
Famotidine.
Okay, and did you choose that one for a reason? Are there other options that could have been considered?
Less drug interactions.
What's her creatinine clearance?
Okay. All right, group number 18. What did you guys decide to give stress ulcer prophylaxis? And if you did, what did you choose? And why?
We would definitely want to use famotidine over a PPI because she already has a history of C. diff. But we weren't really sure if she qualified. She does have sepsis, but she doesn't have any additional risk factors until she's been on the ventilator for 48 hours. So we kind of weren't sure.
Okay. All right. Okay, good. All right. So you guys are kind of bringing up some good things we can talk about. So I would probably say that this patient needs stress ulcer prophylaxis. And then reasons why. So here's a couple of things to talk about. And kind of something that you guys, that we've been stressing in all the lectures that Dr. Hawkins and I have taught. So the ICU is sort of changing. You know, we talked about that either in the sedation lecture or we talked about some of the components of sepsis. So this stress ulcer prophylaxis topic is getting harder and harder to teach from an exam standpoint. Like I can come and tell you all of, you know, what's going on now, the history of stress ulcer prophylaxis, what we've done before, and then I'll have some newer data to show you at the end of even this. So if you guys remember from the pre-class slides, you see the skeletons there, like we've been waiting for stress ulcer prophylaxis guidelines to be updated forever. And the reason is because we're getting a lot of newer data that keeps coming out to say that maybe, you know, our care in the ICU is either maybe improved or the risk for stress ulcer bleeding may be less than we originally thought. So a lot of the data and the risk factors that you guys are talking about or identifying, if you look at that citation, is from that original Cook study that was done in the early 90s. So that was quite some time ago, but we do know from that study, and we're sort of where we're at right now in practice, we know that our two major risk factors that have been identified from that study were respiratory failure and then coagulopathy. And then you have this whole host of other more like secondary or minor risk factors that should also be considered. So kind of how we can, you know, approach this case, or what you're going to see in clinical practice is that, I mean, the patient is in septic shock, they're on vasopressors, right? So hopefully you notice that their blood pressure was maintained, they were maintaining that blood pressure on norepinephrine. So they're in septic shock on vasopressors. And then this patient is on the ventilator. So a couple of things just from a clinical standpoint, but then also looking at some of the newer studies. So we know mechanical ventilation greater than 48 hours is a major risk factor. I will tell you in clinical practice, if the patient comes, if they are intubated or if they are on the ventilator, unless it's for something like they're intubated for airway protection because maybe they had a seizure and that's resolved, or they have some sort of toxic ingestion that is resolving and we know we're going to be able to get them off the ventilator within 24 hours, we pretty typically are going to start them on stress ulcer prophylaxis from the beginning. Because how hard is it to remember, okay, now we're on this clock and 48 hours later, now we need to start, this is when that, you know, really when that risk factor kicks in. So that's a lot harder to remember from clinical practice to make sure that you keep on time with that. So we would typically start this right away. Some of the newer studies, like the study I'll show you at the end of this material, they actually included patients who were on the ventilator or expected to be on the ventilator for 24 hours. So that's an even, you know, kind of smaller subset of patients. So for this patient, in this situation, I would go ahead and start them on stress ulcer prophylaxis based on what we currently know. And then in terms of what medication to choose, I would probably lean towards choosing an H2RA for some of the reasons that you identified. There is this kind of data with an association of PPIs with C. diff is plus minus. We see that there are some studies that have linked a possible association with increased incidence of C. diff with PPIs. Again, I'm going to show you something here at the end that shows no difference. That meta-analysis that I included at the end of your pre-class slides also looked at that as one of their secondary outcomes and showed that there was really no difference in the incidence of C. diff as well. But in general, in my personal preference, I try to stick towards the H2RAs as a recommendation versus the PPIs for a lot of different reasons. But one, for all the things that you guys have identified, so less drug interactions. But a lot of our patients inadvertently go home on the things that we started them on in the ICU. And we do know with all the data that have come out lately with PPIs, with potential, you know, links to different, you know, neurologic diseases, chronic kidney disease, possibly we know about the bone mineral density issues and increased risk of fractures. So I try to stay away from the PPIs unless they have a compelling indication where they need a PPI just from the standpoint in case they go home on it inadvertently, that it's something that maybe is going to have less consequences if they're on it for a longer period of time.
Dr. Brannon?
Yeah.
I have a question. If, say the patient was in sepsis and they weren't like on a pressor yet, and so they didn't have like the ventilation, would they not need stress ulcer prophylaxis.
Okay, so your patient is just septic, not on the vent, and not on pressors. So you have to look at everything else, because if they have any of those other minor risk factors, then that potentially would maybe increase your likelihood to put them on stress ulcer prophylaxis. And some of that is going to be very dependent on your patient's clinical picture. So a lot of times when you've worked in the ICU for a while, you can sort of look at a patient and think, you know, is this something that I expect I can get turned around pretty quickly? Like they're dehydrated, I can probably give them some fluids. You know, they'll improve and then maybe we'll leave the ICU by tomorrow. Or does this patient look like they're headed in the wrong direction? You know, a lot of times, clinician-wise, what we'll do is we'll start them on it if they have any of these types of risk factors and we think they're kind of headed in the wrong direction. But it's something that we should be looking at as our patients are transitioning out. So transitions of care are huge, like in all of our settings, so admission, transferring from floor to floor. So that's something I look at if our patients are ready, if their risk factors are gone, or especially if they're ready to go to the floor, and that's always something that I bring up and say, can we stop this now? We just started this, to try to decrease the likelihood that they're going to go home on it. But again, I'm only there, you know, Monday through Fridays, and we have our clinical pharmacists that can round, so that, you know, there's some patients that may be missed. So that is definitely, I mean, this whole topic is pretty gray in general now, but so that is definitely more of a gray area. It's going to be more clinician and patient specific. All right, good questions. Okay, so part 2. 1 week later, she's off the ventilator and she's been off pressors for more than 24 hours. She still remains nothing by mouth NPO, hopefully you guys know that abbreviation, due to an illness, and she's starting parenteral nutrition today. So, group number 7. Tell me, did you guys decide the patient still needs stress ulcer prophylaxis, and tell me your rationale.
Yes, ma'am.
You said yes? Okay, so I need your rationale. So why you said yes?
Probably more than a week.
That's all I can think of. That she started.
Feeding tube.
Okay, she's a feeding tube. Okay. All right, group number 23. Tell me what you talked about.
We also considered the feeding tube and also her length of stay.
Okay. All right. And then let's see. Group number 5. Tell me what you talked about.
We use the surviving sepsis guidelines, and based off of that, she doesn't have any more risk factors, so we would wean her off.
Okay. All right. So you guys said no. Okay. All right. So let's talk about it. So does she still need it? So I would say probably not. And here are some of the reasons why. So just because a patient, so I see this all the time in clinical practice, just because a patient is nothing by mouth, so their NPO status, they're not eating, that alone by itself is not an indication for a patient to receive stress ulcer prophylaxis. They have to have either these major risk factors or some of these minor risk factors for this to be considered. So her major risk factors have resolved that we talked about, right? So she's not on pressors anymore, she's maintaining her blood pressure, she's not on the ventilator anymore. She may have some minor risk factors, so she may have sepsis that has this potentially resolved now that your patient's clinically improved. If she'd been in the ICU for about a one week stay, then that is potentially a minor risk factor. But I would say probably by and large, for most of what you know about this patient at this point, they probably don't really have an indication for stress ulcer prophylaxis anymore at this point. Does that make sense? Okay. So the biggest takeaway I want you guys to recognize here is just because a patient is nothing by mouth or MPO status by itself does not mean that the patient needs stress ulcer prophylaxis. So this patient, and I heard some discussion about her having a feeding tube. So feeding tube is enteral feeds, right? And that would go into the stomach or possibly like into the duodenum, depending on where you place that. So that would be using the patient's gut, right? And so that is sort of, some people think that if the patient is on enteral feeding that they have criteria for stress ulcer prophylaxis, which that's not really data driven either. But if a patient is on parenteral nutrition, which is, remember, goes through their vein, that's something they're going to get intravenously, then that still by itself is not considered a major risk factor for a patient to develop a stress ulcer by itself. Does that make sense? Okay. All right, so case number 3, I'm going to give you guys maybe 3 to 5 minutes. I'll check in with you guys to see. This is the same patient before. It's your same stroke patient that's going to come in and receive TPA, and he's on the medications that you see here. And then so talk about if you think this patient needs stress ulcer prophylaxis and why or why not.
What is coagulopathy? It's coagulopathy. Is it just like a
It means their blood doesn't.
I mean, if he's on TPA, he's going to be on like enoxaparin. What do you need it?
I mean, that's a risk factor, but the coagulopathy, so he doesn't need it. Right? He needs it because he's got
TPA stuff.
Oh, that coagulopathy. Yeah, like that alone.
Isn't that just where you don't clot?
Yeah, it's like a bleeding disorder or a blood disorder where your blood won't clot.
But he doesn't have that.
His platelets are fine.
So he wouldn't need prophylaxis?
I don't know, but then this anticoagulant therapy is like a risk factor, so
Question, would you consider a stroke a traumatic brain?
Don't they like recommend it for dual antiplatelet therapy anyways? Like I feel like we learned that last
Somewhere,
year
yeah.
in AFib or something.
trauma type, right? I think that means like if you were in like a car accident
It's
and
all
like a
saying
bullet went
trauma.
through your head or something.
So it doesn't have any risk factors.
I guess not.
Does more muscles, Daryl and Fisher will do more muscles.
So like if you see them, you don't have to pay either or. Yeah. I need to go chiropractor at my house, but like all I did was pop my bones. And like I've always had muscle work done.
I have some things like that. Which one?
Dr. Lawson.
trying to get put into him, but they keep making me confused when I go on to the I would be like, I want Daryl, not Randall. Yeah.
Okay, group number 16, tell us what you guys talked about with this case. Did you decide that they needed stress ulcer prophylaxis, and what was your rationale?
Yes, because it's coagulopathy.
Okay, group number 26, tell me what you guys talked about in your group.
We were thinking no because we didn't see any indicated risk factors for it.
Okay, all right. And group number 16, why did you think the patient has a coagulopathy?
We seem to have made an error in our understanding of what coagulopathy was.
Okay, all right, okay. Well, let's just talk about some of the things here. Okay, so I would say maybe. This is really gray and not 100% sure. So I think you'll see potentially both sides of the fence here. So from a stress ulcer prophylaxis, standpoint, the patient's in the ICU currently, they receive TPA, which is, a thrombolytic, which may increase their bleeding risk. Now they're on to antiplatelet agents. So this potentially is a patient that you would classify as a high bleeding risk. So you might consider using stress ulcer prophylaxis in this patient. Now, when the patients start moving out of the ICU, then that terminology of stress ulcer prophylaxis really should be restricted when patients are in the ICU, but you will maybe see some things when patients are on either dual antiplatelet agents or if they're on, the triad with dual antiplatelets and something that's a systemic anticoagulant. You may see some data that suggests that, something to prevent peptic ulcer bleeding is also important. So I would say, the patient doesn't really necessarily have any of those risk factors that we've been talking about clinically, but they are all on dual antiplatelets. So you may see both of these. I would probably tend to give this patient stress ulcer prophylaxis while they're in the ICU, probably with an H2RA, and then look at this, when the patient's ready to go out, kind of revisit that and have that conversation again. Dr. Hawkins, do you want to add anything for this scenario?
Yeah, so I think those emojis are supposed to say that you or I both have questions about maybe. You can leave yours. I would definitely give my emoji 2 thumbs up. Whether they are on the floor or in the ICU or at home, my practice is that if they are on dual antiplatelets, then I would put them on acid suppressive therapy. So I think when I taught you guys acute coronary syndrome as P2s, we talked about the acronym NASH balls, where the H stood for H2RA if they were on dual antiplatelets.
Yeah.
So the COGENT trial looked at patients on dual antiplatelets and whether they got a PPI or not. And PPI given to a patient with dual antiplatelets reduced their risk of GI bleeding by 50%. So that was enough to make me practice giving them acid suppressive therapy. I used to give PPIs if they were on dual antiplatelets, but because of all the adverse effect profile that Dr. Brandon has highlighted today, I tend to only use H2RAs, dual antiplatelets, period.
Okay. All right, good. Any questions on that?
I have a question.
Yes.
What is coagulopathy?
So what is coagulopathy? We're going to talk about that in a second. So and the way that it was defined in that, so coagulopathy can be defined in lots of different ways, but specific to stress ulcer prophylaxis, it is defined by that Cook study, and it's actually included in the pre-class materials about how that is defined in that study when it's looked at as risk factor. But it's going to come up in the next case, so we'll come back to that. Okay, so case 4, this is the same patient again. I'm going to give you a couple minutes to look at whether you think this patient needs stress ulcer prophylaxis or not, and then what your rationale is. So just so we have time, so I can touch on the things at the end that I want to touch on. So case number 4, so group number 11, tell me what you talked about for this patient.
We said yes because of the gastric ulcer.
Okay, all right, and then group number 14, tell me what you guys talked about.
We said yes because of the history of GI bleed within the past year.
Okay, all right, okay, so let's talk about this for a second. So I agree with you, but I'll say no just from the standpoint. So first of all, this is a 4 patient, so make sure you're identifying. So if your stress ulcer prophylaxis is to prevent bleeding from an ulcer, right? So you have a patient that has a different indication. They've had a recent bleed, you potentially don't know how long ago that may have been and where they may be in their treatment per se with that treatment of their gastric ulcer. So to me, I sort of separate that out differently, and I try to get my clinicians to think about that differently, because if you're treating a gastric ulcer, that should have some sort of defined treatment plan versus stress ulcer prophylaxis, which the data has really been driven from our patients in the critical care setting, and then we've sort of extrapolated. Now what you'll see in clinical practice is that's been extrapolated kind of all over the place. And you see 4 patients that have never been to the ICU that are started on quote-unquote stress ulcer prophylaxis. So I want you guys to think about kind of differentiate in your mind, you know, what exactly stress ulcer prophylaxis is and what your clinical setting is. Looking at some of these things that you guys were talking about, so what if she was in the ICU? Would she need stress ulcer prophylaxis? So just like I see some heads nodding here in Athens. So if she was in the ICU, I would say yes, she probably does need stress ulcer prophylaxis, right? So it kind of comes back to the question that Natalie asked earlier. And so she has a coagulopathy, right? So that's defined in those slides. If you look at that original Cook study, so platelet count less than 50,000, INR greater than 1.5. Those are probably the 2 that you're most commonly going to see. I have very rarely ever seen a patient who comes in with an APTT that's greater than 2 times your normal. That's not on, heparin, basically. So the biggest things are looking at, so if they have a baseline INR that's greater than 1.5, and then if their platelet count is less than 50,000. Question? Use your mind.
For coagulopathy, it's and or those 3 criteria. It's not wrong.
It's not wrong. So it's or. So platelet count or INR or APTTs. Yeah. Okay. All right. And the medication-wise, you could do either an H2RA or a PPI. You'll here's some discussion about potentially causes of thrombocytopenia, that potentially there's an association with H2RA. Some clinicians will tell you that it's more prevalent with H2RAs versus PPIs. That's not necessarily true. Both medication classes can cause thrombocytopenia. You can switch from one versus the other to see if your platelet count recovers. But by and large, most of the time that your cause of your thrombocytopenia in the ICU is going to be something else related to their critical illness. Okay, questions about that case? Okay, so these last 2 minutes before we get cut off, because I want to be timely for you guys. So this study was just published 5 days ago in the New England Journal of Medicine. This is another reason why our stress ulcer prophylaxis guidelines have been delayed for so long. So that meta-analysis that came out in 2017, the revised trial that's in your free class stuff, sort of gave us a lot of questions that this trial aimed to answer. So this looked at over 3,000 patients in the ICU who had these major risk factors for these patients that we would typically use stress ulcer prophylaxis on. Their primary outcome was death at 90 days, but then they also looked at a composite outcome. And so then all of these things were combined in their composite outcome. They looked at clinically important ICU events, and they termed those as either clinically important GI bleeding, a new pneumonia, C. diff infection, or acute MI. And again, those things are things that were either identified as potentially being associated with PPI use either from previous studies or things that were identified in that meta-analysis that came out before. And what they found was that there was no difference in your survival. So there was no difference in their primary outcome of death at 90 days. And then there was also no difference in that composite outcome of clinically important bleeding, of all those different things combined. So clinically important events, there was no difference. It is important to note that there was a difference in the amount of bleeding. So you can see there was a higher rate of bleeding, which we kind of would expect in the placebo patients, so 4.2% versus 2.5%. That is technically statistically significant if you look at your confidence.
Every teacher does that.
Wait, maybe it reconnected. Oh, did we reconnect? Can you guys hear me?
Yes.
Okay. All right, good. Okay, well, I was going to say, I'll send an email to highlight the rest of this stuff, but the last point I was trying to make, and I'm not going to test you on this, I just want you guys to be aware that this is where we are, is that they didn't require any patients they thought had GI bleeding. They didn't do any endoscopic evaluations to try to determine, was it a peptic ulcer bleed? Did that bleed occur? Was it a patient who has liver cirrhosis, and was it a variceal bleeding? So it's just something interesting to note, but there was nothing definitive that they really could draw from this. So again, we're seeing more data showing that there really may be no difference. So is there potentially still a need for us to provide stress ulcer prophylaxis to our ICU patients? We're still kind of unsure. So there should be more to come from that later. And that is all I have from a class standpoint. And as far as an exam goes, I'm not going to ask you dosing, like the VTE stuff. You need to know the dosing that Dr. Hawkins has identified for you guys. The biggest things I want you guys to know is sort of where we are at right now with clinical practice. What are major risk factors? What kind of patients would you right now, based on what we know, give stress ulcer prophylaxis to, and which medications would you choose for various reasons that we talked about from class today. Good? All right, thanks guys. Sorry we got cut off. Thank you for staying a couple minutes over. Have a great rest of your week.
Don't worry about it. No, I think, but I don't know why they don't like cut it off at 11:05 because every teacher runs over.
Why don't they just let it run?
Yeah, they should. I don't know. Maybe they don't know that every teacher runs over.
That hurts from sitting all that time.